Imagine you have a violently agitated patient right in front of you. They're a danger to themselves. They're a danger to your nursing staff. And, you need to intervene immediately.
Right, the complete clinical emergency.
Exactly. So you go into your electronic medical record system to order the medication combination that your professional medical college actually recommends as the absolute best practice.
Yep.
And right as you click submit, your screen just locks up.
That dreaded hard stop.
Right. A bright red FDA warning flashes in your face telling you to stop, warning you that mixing these two specific drugs is, like, strictly prohibited. So today we're talking about clinical whiplash.
It really is.
Welcome to this deep dive. For those of you listening, the emergency physicians, the clinical pharmacists, the nurses on the front lines, our mission today is to untangle a deeply ingrained piece of medical dogma regarding the treatment of acute agitation.
Because it is, frankly, one of the most frustrating situations you can face at the bedside. You are caught between regulatory dogma on one side and the immediate physical reality of a crashing patient on the other.
Completely. And we're going to figure out how we got here and, more importantly, what the actual evidence says you should be doing. We're pulling from a really fascinating stack of sources to do this.
It's a great mix of data.
Yeah. We have the American College of Emergency Physicians 2023 Clinical Policy, a breakthrough 2024 retrospective study by Cole et al. In the Annals of Emergency Medicine, some brilliant clinical editorials, and the foundational 2010 Martyr et al. Safety report that basically started this entire mess.
Right. And to really understand why your hospital's EMR is yelling at you today, we have to start with that 2010 Martyr report.
We have to look backward.
Exactly. We need to causally link today's warnings back to the historical origin of this fear surrounding the co-administration of intramuscular olanzapine and, well, parenteral benzodiazepines.
Because the warnings are severe. I mean, the FDA has strict labeling precautions, and the European Medicines Agency, the EMA, goes even further.
They have that infamous 60-minute rule.
Yeah, they explicitly state you should not give these two classes of medications within 60 minutes of each other. The stated fear is severe excessive sedation and cardiorespiratory depression.
Right.
And when you trace the citations back through the literature, almost all of this institutional anxiety essentially funnels back to that single 2010 paper by Martyr and colleagues.
It does. And we need to look at how that 2010 paper was constructed because the methodology is really the root of the problem here.
Okay, let's unpack this. What did they actually do?
Well, Martyr et al. Analyzed a post-marketing database provided by the drug manufacturer. They were looking at the first 21 months that injectable olanzapine was available on the market in the United States.
Okay.
And during that time, out of an estimated 539,000 worldwide exposures to the drug, the database captured 160 adverse events and 29 fatalities.
Wait, hold on. 29 fatalities out of over 500,000 exposures.
Yeah. That is a fraction of a percent. I mean, it's roughly 0.005%. Why did a number that's staggeringly low trigger a global regulatory lockdown on these medications?
It's because of the nature of the fatalities and really how post-marketing surveillance works. In systems like the FDA's Adverse Event Reporting System, or FARIERS, data is voluntarily reported and largely unvetted for causality.
So it's just raw data.
Exactly. If a patient receives a drug and subsequently has a severe outcome or dies, it gets logged. And regulatory agencies are highly sensitive to any signal of mortality associated with a newly approved drug, especially psychiatric medications.
Oh.
So when they saw 29 deaths, they didn't wait for a randomized controlled trial. They just acted on the raw signal.
But when you actually read the clinical narratives of those 29 patients in the source material, the quote-unquote signal completely falls apart.
It really does. I mean, blaming the specific combination of olanzapine and benzodiazepines for those deaths is like looking at a patient who presents with massive multi-system trauma, septic shock, and a gunshot wound, giving them a Tylenol for a fever, and when they die, the regulatory agency puts a black box warning on the Tylenol.
That is the perfect way to describe it.
It just completely ignores the catastrophic compounding variables.
It does. When you synthesize the reality of those 29 fatalities, the compounding variables are massive. Get this, out of the 29 cases, only a single fatality involved a patient receiving just IM olanzapine and a benzodiazepine.
Wait, just one?
Just one.
Huh.
25 of those 29 cases involved incredibly heavy polypharmacy. We're talking about patients who were given multiple other typical antipsychotics, additional sedatives, and various other central nervous system depressants, all concurrently.
Oh, wow. And the temporal disconnect is even wilder. 12 of those patients died more than 24 hours after receiving the medication.
Well,
The sources note that one patient died 9 days later from a completed suicide. Another patient died from U poisoning, which is a toxic plant.
right, it's absurd.
How does a regulatory body draw a direct pharmacodynamic link to an immediate drug interaction when the peak effect of the medication happened a full day or several days before the patient consumed a poisonous plant?
Mechanistically, you can't. There is no biological plausibility there.
Obviously.
But because it's a voluntary retrospective database, the regulatory bodies are forced to cast a wide net. That loose temporal association was enough to trigger extreme regulatory caution.
And the dominoes fall.
Exactly. The warnings were stamped onto the official drug labels, the EMA created their 60-minute rule, and hospital bureaucracies across the world institutionalized those warnings into their locked medication cabinets and EMR hard stops.
So what does this all mean for today? Fast forward to the fall of 2023. ACEP releases a clinical policy on severe agitation. And they actually recommend using an atypical antipsychotic, like olanzapine, in combination with a benzodiazepine, like midazolam. They are directly contradicting a standing FDA precaution.
They are.
How is an emergency physician supposed to practice safely when the FDA says stop, but the ACEP guidelines say go? Why would a leading medical college push that?
This raises an important question, right? To answer that, we have to look at the clinical reality and the mechanism of the emergency itself. Severe agitation in the emergency department is not just a behavioral nuisance.
Right, it's a medical emergency.
It is a profound, life-threatening physiological state. A patient who is violently agitated, fighting against physical restraints, is in extreme sympathetic overdrive.
We're talking about restraint-associated cardiac arrest, right? That cascade is terrifying to watch. The patient's body essentially just burns out from the exertion.
Yes, exactly. When a patient is violently struggling, their system is flooded with catecholamines, adrenaline, and noradrenaline. They're burning through energy stores, which leads to massive lactic acid production.
And the pH drops.
Right, creating severe metabolic acidosis. At the same time, the sheer mechanical breakdown of muscle tissue from straining against restraints causes rhabdomyolysis, which dumps potassium into the bloodstream.
Which is incredibly dangerous for the heart.
Exactly. So now you have a heart beating at 160 beats per minute in an increasingly acidic, hyperkalemic environment. It is a perfect recipe for a fatal cardiac arrhythmia.
Which means time is tissue. You cannot sit there and hope they calm down. And, you can't wait for a gentle, slow-acting oral medication to kick in.
No, you can't.
You need to chemically break that sympathetic feedback loop immediately to save their life.
And that is why the combination is so therapeutically brilliant. Agitation is usually multifactorial. If you only give a benzodiazepine, you are solely targeting the GABA-A receptors.
Right, the general sedation.
You're opening chloride channels to hyperpolarize the neurons. But if the patient's agitation is driven by an underlying psychosis, their dopamine and serotonin pathways are still firing wildly.
So by adding the olanzapine, you attack the problem from two distinct physiological angles.
Correct. Olanzapine specifically blocks dopamine D2 receptors and serotonin 5-HT2A receptors, which directly lowers the psychotic drive.
Okay, that makes sense.
You combine that with the generalized calming effect of the GABA-agonizing benzodiazepine, and you achieve rapid, effective behavioral control much faster than using either drug alone.
So the benefit is massive.
The clinical need to rapidly sedate a dangerously agitated patient heavily outweighs a theoretical warning derived from a decade-old, highly flawed database.
But theory only gets you so far. If you are an emergency physician, you need more than just receptor physiology to confidently override an EMR warning.
You need proof.
Exactly. You need hard, objective data showing that this combination doesn't actually cause patients to stop breathing. To resolve this massive contradiction, researchers finally needed to look at clinical endpoints, which brings us to the breakthrough 2024 retrospective study by Cole et al. In the Annals of Emergency Medicine.
And this study is the critical turning point in the literature. Researchers at Hennepin County Medical Center decided to look at hard, undeniable clinical endpoints.
Yep.
They reviewed 693 patients who presented to the ED and received 2 doses of sedatives within 60 minutes of each other.
And the way they designed this study is what makes it so incredibly useful. They didn't just look at subjective nursing notes about, excessive sedation.
No, they looked for tracheal intubation.
Exactly. That is the ultimate objective sign of cardiorespiratory failure. If the FDA's fear of severe respiratory depression was true, you would expect to see a massive spike in intubations when these drugs are mixed.
Absolutely. And what's brilliant about the study design is that they strictly limited their inclusion criteria to patients who received only 2 doses.
Only two.
No extra droperidol, no haloperidol, no ketamine. By strictly limiting the pool to 2 doses, Cold et al. Cleanly isolated the interaction. They filtered out the noise and completely avoided the polypharmacy trap that totally ruined the 2010 Martyr data.
Right. So they broke the patients into two groups. You had 549 patients who got 2 doses of olanzapine and 144 patients who got olanzapine plus a benzodiazepine, specifically midazolam, lorazepam, or diazepam.
And the results are incredibly reassuring.
Yeah, when you look at the intubation rates, they were basically identical.
The numbers are very compelling. The intubation rate for the olanzapine-only group was 3.8%.
Yeah.
For the olanzapine plus benzodiazepine group, it was 3.5%.
Wow.
There was absolutely no statistically significant difference in the primary outcome of severe respiratory failure requiring a breathing tube.
And what about the secondary outcomes? Did adding the benzo cause massive drops in oxygen or blood pressure?
No. Whether you looked at their oxygen levels dropping or their blood pressure tanking, the numbers were nearly identical across the board.
Oh, really?
Yeah. Hypoxemia, defined as an oxygen saturation dropping below 90%, occurred in just 2% of the olanzapine-only group and 3% of the combination group. Hypotension hovered right around 9% for both groups. Statistically, adding the benzodiazepine did not move the needle on harm.
That's huge. But let's introduce the clinical reality of the emergency department for a second, because we have to pressure test these findings. Your severely agitated patients aren't usually presenting with a clean system. They aren't just agitated, they are often highly intoxicated.
Which is the true pressure test of these findings. We have to look at how these drugs perform in the highest risk subgroup in the ED.
Right, and the Cole study captured this beautifully. Over 80% of the patients in their cohort had alcohol or drug intoxication on board, and the median blood alcohol concentration for these intoxicated patients was a staggering 210 milligrams per deciliter.
That is a massive amount of alcohol.
It really is. So I have to play devil's advocate here. Looking at the physiology, alcohol is a major central nervous system depressant. It enhances GABA receptor activity just like benzodiazepines do.
It does.
So if you inject a patient who has a DAC of 210 with an antipsychotic and then inject them with a benzodiazepine, you are essentially stacking 3 major CNS depressants. Shouldn't the patient's respiratory drive just completely shut down?
It is a highly logical fear. And based on the pharmacodynamics, alcohol absolutely increases the baseline risk of respiratory depression for any patient receiving sedatives.
Okay, so the risk is higher.
But the critical finding from the Cole sub-analysis was about synergistic risk. While the baseline risk was undeniably higher for intoxicated patients, the sub-analysis showed no statistically significant synergistic risk between the two drugs, even with that massive amount of alcohol on board.
So the drugs didn't multiply each other's dangerous effects in some unpredictable way.
Right. To be completely transparent with the data, the intubations in the alcohol subgroup were numerically higher for the combination therapy, 6.4% versus 3.6% for olanzapine alone.
Okay.
The study was slightly underpowered to declare a definitive statistical difference there, so we can't say the risk is absolutely zero. But crucially, no massive harm signal was detected.
The sky didn't fall.
Exactly. It wasn't jumping from 3% to 25%.
So for the clinician listening, the bedside takeaway is nuanced but clear. Monitor these intoxicated patients incredibly closely because their baseline risk is obviously elevated.
Right. Always monitor.
But don't withhold unnecessary life-saving chemical restraint just because they have alcohol in their system. The profound metabolic acidosis and cardiovascular strain of the agitation itself might kill them far faster than a hypothetical synergistic drug interaction.
That is the essential risk-benefit analysis right there. But to truly resolve this debate, we have to look at another layer of the pharmacology.
Okay, what's that?
If the molecules themselves aren't inherently toxic when combined, why were there historical reports of patients crashing? The sources reveal that beyond what drugs are given, the hidden culprit in this entire debate might actually be how they are given the route of administration.
Oh, this is where it gets really interesting. The pharmacokinetics completely reframe the conversation.
They really do.
If you look at the 2013 Chan et al. randomized clinical trial, They approached the co-administration entirely differently. They used intravenous midazolam and intravenous olanzapine.
A V instead of IM.
Exactly. And their results were wild. They actually found less oxygen desaturation in the combination group, 4.6%, compared to patients who just got midazolam alone, who had a 7.8% desaturation rate.
It seems completely counterintuitive at first glance. Why would giving two sedatives cause fewer respiratory issues than giving one?
Right.
The secret lies entirely in the pharmacokinetics of the intravenous route compared to the intramuscular route.
Because 5E absorption is instantaneous.
Right, exactly. When you give IV olanzapine, it enters the central circulation immediately. It works much faster, which means it requires a significantly smaller dose to achieve the desired clinical effect.
That makes sense.
In the Chan trial, they were using around 5 milligrams of 5E olanzapine compared to the standard 10 milligram intramuscular dose. Furthermore, because it's 5E, the physician can accurately titrate the medication. You push the drug, you see the effect almost immediately, and you can stop.
Contrast that with how intramuscular injections work in a chaotic ED environment. This brings up the phenomenon of dose stacking.
Yes, the dose stacking trap.
Think about it like impatiently hitting the button for an elevator or a crosswalk. You hit the button, the elevator doesn't come immediately, you get frustrated, so you hit it again and again.
That analogy perfectly illustrates the clinical trap of IM absorption. When a doctor gives 10 milligrams of IM olanzapine, it creates a depot in the muscle tissue.
Right.
It has to slowly absorb into the bloodstream. It can take anywhere from 15 to 45 minutes to reach peak serum concentration.
So 10 minutes go by, the physician sees a patient is still violently agitated and fighting the restraints.
And they're under pressure.
Right. The doctor gets nervous, feels the pressure of the situation, and decides to give an IM benzodiazepine.
And that is where the accidental overdose occurs. You've hit the elevator button twice. Suddenly, 30 or 40 minutes in, that initial large 10 milligram dose of IM olanzapine finally peaks in the bloodstream. At the exact same moment, the benzodiazepine reaches its peak effect.
Oh.
Both medications flood the central nervous system simultaneously. The patient crashes, their respiratory drive drops, and to the untrained eye, it looks like a deadly, toxic drug interaction.
But it's not a molecular interaction at all. It's an accidental pharmacokinetic overdose caused by the unpredictable delay in IM absorption.
Precisely.
A true danger wasn't combining the olanzapine and the midazolam. It was the timing and the route leading to accidental overmedication.
When you utilize the IV route, or when you are disciplined enough to adequately space out or anticipate the peak of the IM route, the safety profile changes dramatically. The science heavily supports the safety of the combination when administered with an understanding of pharmacokinetics.
Which brings us to the most frustrating reality of modern medicine. Proving the science is only half the battle. Reading the Cole et al. And Shan et al. Data is great, but the other half is fighting the hospital bureaucracy that enforces outdated warnings.
Yes, the bureaucratic inertia is a massive threat to optimal patient care. If we connect this to the bigger picture, Dr. Brian Hayes wrote a brilliant editorial in 2024 addressing this exact operational bottleneck.
Yeah, his editorial is spot on.
He points out that the institutional restrictions physicians face daily, the EMR hard stops, the locked medication cabinets requiring specialized override codes, these are all still anchored to that old EMO 60-minute rule and the fundamentally flawed MARTYR data from over a decade ago.
And the maddening part is that FDA labeling is rarely, if ever, updated to remove warnings, even when high-quality modern data like the Chan or Cole studies completely refute them.
It's very static.
Right. Once a severe precaution goes on a drug label, it takes an act of Congress to get it removed. Medical science moves forward, but the regulatory labels just remain frozen.
Dr. Hayes makes a compelling argument regarding how we should handle this discrepancy. He argues that hospital medication precautions shouldn't be based on blanket, outdated rules pulled from outpatient databases.
Right.
They should be based on the patient's immediate clinical condition and the level of monitoring available in that specific unit.
Which highlights a massive difference between, say, an unmonitored psychiatric floor and a level 1 trauma center emergency department.
Precisely. The ED is uniquely equipped to manage the exceedingly rare instances of respiratory depression. You have continuous cardiac monitors, continuous pulse oximetry, end-tidal CO2 monitoring, and an airway cart sitting 10 feet away from the bed.
If there is a place to safely use these highly effective calming agents, it is the emergency department. We shouldn't let a warning designed for a totally different clinical setting dictate the care of a critical, crashing patient who is actively developing metabolic acidosis from agitation.
It requires a major paradigm shift at the institutional level.
Which is the ultimate call to action for you, the listener. You cannot wait for the FDA to update a label. You could be waiting decades.
Serious.
Clinicians need to lead the way locally at their own institutions. Take the ACE guidelines, take the Cole study, and work directly with your pharmacy and therapeutics committees to develop updated, evidence-based ED agitation pathways.
Absolutely.
You have to build order sets that actually reflect the rigorous science of today, not the flawed, voluntarily reported databases of 2010.
It requires local champions who are willing to look at the data critically, understand the physiological mechanisms at play, and advocate for system-wide changes that allow doctors to do their jobs effectively and safely.
So let's summarize this journey. We started by unpacking a shaky, polypharmacy-riddled safety report from 2010 that basically scared the regulatory world into slapping severe warnings on these medications.
Yep, the Marshall Report.
We then explored the profound physiological dangers of acute agitation, leading to a bold clinical recommendation by ACP in 2023 to use the combination anyway. Finally, we looked at the rigorous vindication provided by recent studies, particularly Cole et al. In 2024 and Chan et al. Before them.
And the evidence clearly demonstrates that the olanzapine and benzodiazepine combination is not just highly effective at preventing agitation-related morbidity, but it is remarkably safe when managed correctly.
Especially when you account for the route.
Exactly, especially when clinicians understand the pharmacokinetic risks of IMM dose stacking.
It is an incredible evolution of medical knowledge and a testament to the importance of questioning the foundational data we base our protocols on. But as we wrap up this deep dive, I want to leave you with one final, slightly unsettling thought to mull over during your next shift.
Okay.
We just spent this time proving how a highly flawed 14-year-old database report dictated global prescribing practices and locked up hospital EMR systems for over a decade. It makes you wonder, what other black box warnings in emergency medicine are we blindly following today that are actually harming patients by preventing optimal care?
That is a question every single clinician should be asking themselves.
Thank you for joining us on this deep dive. Keep questioning the rulebook, follow the evidence, and stay safe out there.